Welcome to this activity on real-world evidence for immune thrombocytopenic purpura, ITP, treatment. I'm David Steensma from the Dana-Farber Cancer Institute and Harvard Medical School in Boston, and I'm joined today by Dr. Eileen Weitz.
I'm Eileen Weitz. I'm from the University of Southern California.
So things have changed a little bit in the last few years with respect to how we approach patients with ITP. There have been several new drug approvals. Now that there are several different agents that all have a similar mechanism of TPO agonist activity, how can we distinguish between these agents in terms of their activity? Are there differences in how they work?
Well, I think that there are distinct differences in where these TPO mimetics bind to the TPO receptor. And for most patients, that's not a big issue. For patients, for example, who have aplastic anemia, if they're using this, and they may have an immune component to their thrombocytopenia as well, eltrombopag may have a more selective role than romiplistin. On the other hand, we have a patient right now who had not responded to eltrombopag and was responding to romiplistin with aplastic anemia. So go figure. But ideally, there are some subtle differences. For the bulk of ITP patients, it probably does not make a difference.
Okay.
And I think that's probably true for eltrombopag as well.
So some of the TPO agonists also have chelation activity and others don't. Does that matter in terms of patient choice or in terms of efficacy of the drug?
Well, I'm not sure it matters in terms of efficacy, but at very high dose, eltrombopag does cause iron chelation, and whether or not that affects general or global hematopoiesis may be an issue. And I don't think that's an issue with eltrombopag.
Okay. And we've recently learned how iron actually deficiency causes thrombocytosis. That was a plenary session at the most recent ASH meeting. So does that have any influence in terms of the likelihood, this chelation activity, of causing thrombocytosis as an adverse event?
Well, I wouldn't consider an adverse event in those patients, okay. Because that's sort of what you want. But yes, I mean, that may aid in the response rate. But we know that even if it doesn't cause chelation, like romiplistin does not cause chelation, eltrombopag, and they're very effective agents. So I don't think it really makes that big a difference. If you're on super high doses, yes, if you'll turn sort of gray, you know, so your blood will be a funny color when they draw it.
So, you know, eltrombopag and romiplistin have been around for a while now, and we have long-term data with those agents. Can you say anything about safety of those agents long-term now in terms of treating ITP? I don't know how long the longest patient that's been treated is.
Wow, some of those patients have been on treatment, boy, probably close to 7 or 8 years or longer. And they don't seem to have any increase in toxicity with long-term use. If they respond, and they keep responding. So if they don't respond to one, then frequently we'll try another and see if they'll respond to that. Sometimes it's a matter of the dosing, and especially with eltrombopag, because you have to be very careful with taking food with it. It has to be spaced out 2 to 3 hours after a meal, 2 to 3 hours before a meal, no calcium. That's problematic for the patients. So it takes, the patient may not be getting the dose you really want them to get the response. With other agents, with romiplistin, that's not a problem. With eltrombopag, that's not a problem.
Okay. Now, when a patient responds, do you ever think about taking them off? And if so, how do you decide when to stop therapy if a patient has a favorable response to one of these agents?
We do. We try to tailor the dose, one, so that the patient's platelets are between 50 and 100 or 150,000. There's really no reason that they have to have a normal platelet count. And yes, then we would cut the dose in half and see how they respond. And if they respond, then we would modulate the dose down. Frequently, what we've done before that is taper off their other ITP medications. So we would do that first before trying to adjust the dose of the thrombomimetic.
Okay. And with respect to other ITP medications, it seems like compared to 15 years ago, the order of therapies has changed a little bit. You know, it used to be steroids and then splenectomy and then, you know, maybe rituximab and then, you know, one of these TPO agonists would be a last resort. How in your practice do you sequence therapy now in 2019?
So I think that the order has changed. Part of that is that people are very reluctant to part with their spleens, and their doctors are very reluctant to have them part with their spleens. Not that it doesn't work, but splenectomy comes with a host of other complications. So people are trying to do without having to do a splenectomy. So it depends on the group of patients. If I have a young woman in her, you know, who's under 40, I might go with steroids up front and an immune modulator. Especially, you know, there were no controlled trials on using rituximab in these patients, but the group that does the best are these young women.
Sure.
Otherwise, we would probably go with steroids and an immune modulator, try to get the patient off the corticosteroids because of long-term complications with corticosteroids. And then if there's no response, we would use something like a thrombomimetic up front. The big issue is that the original definition of chronic ITP required 6 months of unresponsive thrombocytopenia.
Right.
So I think most people don't really wait that long anymore, and they're much more aggressive in trying to get the platelet count up so that there are less complications.
So along those lines, you know, my primary focus clinically and academically has been myelodysplastic syndromes. And back over 20 years ago when ASH came out with a guideline set for ITP, they recommended doing a marrow. I think it was in everyone over 55 or 60 who presented with what looked like ITP in order to rule out myelodysplastic syndrome. Is that still necessary, or do you feel like things have changed with respect to how we approach ITP and the diagnostic workup?
Yeah, I think if there's isolated thrombocytopenia, many people would consider deferring the marrow, even if they're around 50 or 60. But the truth is that ITP is a disease of older people as well, and more often older men than you see in women. So if they have no other cytopenias, we might defer the marrow, but if they have any other evidence of cytopenias, they really do need to have a bone marrow done at that time.
And we had hoped that next-gen sequencing would help, that if we found a clonal mutation in the blood, that would provide strong evidence for MDS, and if we didn't, then more likely an immune mechanism. But now that we've learned about clonal hematopoiesis of indeterminate potential, there's a lot of older people who have mutations and they don't have MDS, so it complicates matters even if you find a DNMT3A or TET2 mutation. So there's been some safety concern about these agents in myelodysplastic syndrome. It's not a labeled indication. The romoplastin trial was stopped early by the data monitoring committee, and then more recently one of the eltrombopag randomized studies showed a little bit higher rate of progression in the active arm compared to the placebo arm. So you know, in my practice, we've been cautious about using these agents, although we still do use them for people with heavy platelet transfusion dependence. They become alloimmunized in the hope that maybe that'll help. It's a little bit of a different situation, though, in that we don't really know that there's an immune mechanism per se. So I wonder how important it is what the mechanism of the thrombocytopenia is in terms of the activity of these agents.
Well, I think it does make a difference, probably because if you have myelodysplasia, you don't have a responsive end organ. So the likelihood of getting a response is somewhat lower. And the original romiplastin studies did show there was a sort of global hematopoietic effect, and the risk of developing worsening MDS existed. So we really don't have a lot of data to support using it in MDS, although there are trials, and some of the trials do show that it decreases the use of platelet transfusions. And these patients are so heavily immunized that after a while that you're really stuck.
Yes. Yeah,
you're really stuck.
Sometimes we're willing to accept that small risk of disease progression in order to prevent a bleeding event or you know, needing platelets every 3 days.
The trouble is that there's no data on combining that with hypomethylating agents, and maybe that would be a strategy to look at because it might allow for these patients to become more platelet independent.
Right. Yes, we don't have any randomized data. There's some phase 2 data that looked like maybe there wasn't much disease progression, but we don't know in a randomized fashion. That's true. So along those lines, with respect to indications that aren't exactly ITP, one of the recent approvals was to get the platelet count up to 50 to facilitate a procedure in somebody who had thrombocytopenia, whether it was from ITP or liver disease or some other cause. I just wonder about your thoughts about, this happens so often in clinical practice where the radiologist says, I'm not going to biopsy this, or I'm not going to put that line in until you get the platelet count up to X. And so I wonder first about your thoughts on those kind of arbitrary thresholds, and then second, TPO agonist strategy versus just transfusing a patient or some other approach?
So, I mean, they are arbitrary cutoffs. When we did the original romiplastin trial, we looked at bleeding risk, and the break point was clearly below 50,000. There was some increased bleeding. Above 50,000, there was no increased bleeding. However, the true, really significant cutoff was actually 30,000. So, and in leukemia treatment, our patients are usually under 30,000 most of the time. So if they need a procedure, it's really hard to keep them up at 50,000.
Right.
So, we just had a case this week of a patient who's got cirrhosis, who was on a TPO mimetic. His platelets were in the 20s to 30s, had to have a pacemaker placed for sick sinus. And we elected to continue his eltrombopag and push his dose up. We gave him romiplastin. He still didn't respond. We gave him platelets. They put it in safely, and his platelets were 28,000. And he didn't have any bleeding. So I think, you know, the cutoffs don't always match with the clinical scenario.
Right.
And some of our surgical colleagues, like our neurosurgical colleagues, want platelets of 100,000. That's not based on anything in the literature.
Right. Thank you. Yes.
Welcome.
This is an everyday thing. It comes up, and it's often a debate. And you know, for a patient with leukemia or MDS, where the platelets that they may make may be dysfunctional, that's a different situation than someone with ITP, where they usually work pretty well.
I think actually in this patient that we had this week, I would have been actually eager to use eltrombopag because it has a faster platelet recovery, or so it seems, on day 8. They seem to have higher levels than with either romiplastin or eltrombopag, but whether or not that really pans out. And there are trials in liver disease looking at that.
Okay.
Yeah.
There had been some concern early on that long-term use of these agents might result in reactive fibrosis either in the marrow or elsewhere. Has that been supported by longer-term literature? I imagine we only have that with eltrombopag and romiplastin.
Well, we had it with romiplastin, and when they looked at that, in the original phase 2, the top level of romiplastin was 15 mics per kilo.
That's high.
And they really only saw the fibrosis, and I had one of those patients, in the group who were on the higher dose, over 10 mics. That's why they capped the dose at 10 mics.
Okay.
So that's why. So they may not really, in theory, you might respond at a higher dose, but because of the fibrosis, they didn't want to go there. With eltrombopag, they did see originally some increase in the marrow, but nothing compared to what they saw with the romiplastin.
Okay.
You know, you can have cataracts associated with the eltrombopag. Everything you get, there's a trade-off for what you get.
Right.
Yeah.
So there was also fosfomatinib, this Syk inhibitor was recently approved. Where do you think that fits in terms of treatment of patients with thrombocytopenia?
I think it does have a role. The response rate was not that high, and the downside was diarrhea. That is manageable. But I think that drug may be useful in other immune diseases and have less of a role in ITP. But in refractory patients, it might be worth a try.
When you say other immune diseases, you mean like rheumatologic conditions where there's thrombocytopenia?
Like autoimmune hemolytic anemia,
Oh, okay.
where there's a higher response rate.
Gotcha.
So, but I think that if I do have one very refractory patient who has a platelet count usually of under 10,000. She gets IVIG intermittently, and but she really doesn't have major bleeding, and that she would be somebody that I would consider trying it in, and I presented it to her when she's not flying around the world. So, yeah. Again, the way we treat ITP is very different than we did 15 years ago, even 10 years ago. And I think that the role of these thrombomimetic agents has really changed our approach. In some ways, I have to acknowledge Dave Cooter for being, for bringing it to the fore so that we to avoid doing splenectomy. And I think that although splenectomy works, again, there weren't any controlled trials doing that. It's all historical data.
Right.
I mean, I grew up in the era where that was a second-line therapy.
Yes.
So, but I think that it does come with complications, pulmonary hypertension, which was unrecognized, splenic vein thrombosis, portal vein thrombosis, so, and the infectious complications. So I think that it's really given us a better option for these patients, and since there doesn't seem to be any long-term adverse effects, that they can stay on this for years.
Yes. And then if splenectomy didn't work, you were left with a laundry list of things where there was a series of 3 patients who were treated with azathioprine or
danazol or
vinca
vincristine or all these other things. And these drugs do work in patients who had a splenectomy. So, and in the original romiplastin and eltrombopag trials, they had both arms, patients who had not had splenectomy and those that had splenectomy. So, and both groups had responses. So it didn't really matter.
Okay.
But yeah, the longer you have the disease, the less likely the splenectomy is going to work.
Sure.
So
eltrombopag has different dosing for East Asian populations. Is the same true of avatrombopag? I don't know.
I don't think so.
Okay.
I'd actually like to see that drug used in aplastic anemia instead of eltrombopag. I think that might actually, one, because of the fast response.
Right.
And maybe the fast response is because it's absorbed better. And so I'd sort of like to see that. That's something we're actually talking with them about.
I mean, the papers from the NIH about aplastic anemia and combining TPO agonist with immunosuppressive therapy have changed how we approach those patients for whom transplant's not the initial treatment. And, you know, the big advantage is a rapid response with eltrombopag plus ATG-based therapy. So if avatrombopag were even more rapid, that really could be a benefit for patients.
Exactly.
But are there studies ongoing in aplastic anemia?
Not at the moment, but we've actually been talking with the company about that.
Okay.
So I think it would, there's certainly no reason to suspect it would not work.
Right, okay, that makes sense.
You know.
Why eltrombopag was that used in aplastic anemia and not romiplastin?
Maybe because some of the original patients really hadn't responded to anything. And with romiplastin, you have to come in once a week to get your dose, whereas this is a pill, and you can take it as a pill. And also, it does work differently than romiplastin. So romiplastin binds to the TPO receptor arms, whereas eltrombopag and avatrombopag bind to the intramembrane part of the receptor. And the theory being that it's gamma interferon that's binding and suppressing, interfering with the ability of TPO to bind to the receptor, and that you can kind of skirt around that by giving something that binds to the intramembrane part.
Makes sense.
So that's the theory, as I understand it. So that might explain why it's more effective than romiplastin in that disease. But, you know, aplastic anemia is an immunologic disease, and some of these patients have an immunologic thrombocytopenia as well.
Right. Getting back to ITP for a minute, you know, for many years, patients would be treated initially with prednisone or prednisolone, and then some data came out suggesting short course of dexamethasone for the initial episode was highly effective. How do you use corticosteroids in patients who've newly been diagnosed with ITP?
Well, we like that high-dose dexamethasone for 4 days, 3 or 4 cycles every 2 weeks. We like that a lot because there are a lot less side effects. Granted, they may not be able to sleep for 4 days, but they don't get all the cushingoid features, and so we like that a lot. But if the patient's platelets drop down again, frequently you have to put them in the interim, you may have to add prednisone. But I like that high-dose dexamethasone regimen. We use that in a lot of our immune-mediated disorders.
Do you have to consider pneumocystis prophylaxis with the dexamethasone pulses or not because it's such a short course?
We usually do not.
Okay.
Because it is short course. But you're right, it's a great T-cell suppressant.
Yeah.
So, and since at least a third of patients really have a T-cell mediated disease that's causing their ITP. Yeah. But in general, we have not done that.
So, Dr. Weitz, are there data on survival? We know that these agents have a quite high response rate, that they're very useful as so-called salvage therapy if corticosteroids have not taken care of the problem. But are there actually data that they extend life or not?
Well, I think that to a certain extent there is, that you can stay on these for a really long period of time. And so these patients would either have had bleeding events that would have shortened their overall survival.
Okay. Well, thank you for participating in this activity. Hopefully it's been helpful for you in treatment of your patients with ITP and other forms of thrombocytopenia. Dr. Weitz, thank you for being here.
Thanks very much.